and provide any updates. We will have questions after the opening introductory summary. After that, as I said, we'll have the questions, but we'd like to turn it over now to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. We'll start with the usual data brief, globally and nationally first. Across the world this morning, there were more than 4.7 million cases of COVID-19 reported and 315,000 deaths. In the United States, we were reporting nearly 1.5 million cases and 89,500 deaths. Here in Minnesota, we have a new total of 16,372 laboratory-confirmed cases. This is up about 700 in each of the last couple of days, 698 on Saturday, an additional 705 on Sunday. I will note that the doubling time that we keep talking about, the number of days in which it takes for the total case count to double, is now at 12 days, which is longer than it has been for the last couple of weeks. So the doubling time lengthening is something that we consider to be not definitive, but a positive sign of the relative stable growth, if you will, of the epidemic here in Minnesota. We are always quick to say, though, that we know that can change very quickly with very little notice, but that is one metric that we look at as a measure of kind of how we're doing overall with the spread of the disease. Unfortunately, we had an additional 9 deaths yesterday from COVID-19, bringing us to 731 total. I will note, however, that daily increase in mortality results is the lowest daily count of deaths from COVID-19 that we have had for the last month. 5 of the deaths reported yesterday were in Hennepin County, 2 in Anoka, and 1 each in Ramsey and Washington. This total includes 3 people in their 90s, 3 people in their 80s, 2 in their 70s, and 1 person in their 50s. 8 of these 9 deaths occurred in residents of long-term care facilities. There are currently 488 patients in the hospital. 229 of them are in intensive care. The hospital measure is also fairly stable. We saw a decrease, actually, of 11 hospitalized patients between Friday and Saturday, and then a net increase of just 1 yesterday on Sunday. So the hospitalization number, and particularly the ICU number, also has been remaining relatively stable in recent days. I'll also note that in terms of the total number of cases released from isolation, that is now 10,764. That represents over 2/3 of the total cumulative cases since we've begun tracking laboratory-confirmed cases starting on March 6th. So over 2/3 of those total cases have now been released from isolation. So that's kind of just the data report. We certainly can go into more on with your questions as we get into questions. I'd like to just give you a little bit of an update, though, on the long-term care 5-point plan that the governor and I introduced a little over a week ago now. As you recall, a couple of the key points of that plan were to increase testing in long-term care facilities, such that any facility with 1 confirmed case of COVID-19 or 2 or more people with symptoms, even prior to testing, that would trigger a plan to test everyone, staff and residents in those facilities. And we've been working hard to get that up and running. Not only the new testing protocol, but more state support for the logistics of getting that testing to happen in long-term care facilities has been our focus over the last week or so. And we've made pretty good progress on getting a system in place to increase that testing. We've sent mobile testing teams out to 21 facilities. An additional 54 facilities are in the queue, if you will, and are being scheduled for that testing. Another really important part of the long-term care plan has been to continue to provide emergency staffing support when long-term care facilities find themselves suddenly short of critical staff and unable to provide staffing for a shift or for a weekend. And we've had a number of instances where staff have been marshaled and pulled together from volunteers and even some National Guard support on a couple of occasions. I'm happy to say that there were no staffing crises of that nature that were managed this past weekend, but we are also working to try to build up a more robust system for the predictable staffing shortage issues that we're going to continue to confront in long-term care over the coming weeks and months, and we're happy to be making progress on that front too. Just building up sort of a core that we can go to for providing some bridge staffing, including, I'm happy to say, some nurses who are coming to us from the Veterans Administration system to help with kind of that bridge task force in the short term. We also, as we've talked before, have teams ready to make on-site visits as soon as a facility becomes COVID positive, and those teams continue to get refined with epidemiologists, folks from our health regulation division, infection control, and increasingly bringing in our partners in local public health to get on site with these facilities as soon as possible to provide the technical assistance that they need around testing and infection control, better training on how to properly use personal protective equipment, and help for these facilities in thinking ahead about their staffing needs and how to prepare for a staffing crisis. So I'm really appreciative of all the work and all the interagency collaboration that's going into improving and further strengthening our plan for anticipating and supporting long-term care's needs. Just on the testing front, more broadly, the data that I reported earlier from the 705 tests that were confirmed yesterday, that was on a volume of just over 6,000 tests that were processed by all the labs reporting on Sunday. That's a big number for a weekend. However, it's a slightly lower level than we had seen in the prior days. And we typically see lower levels of testing happening on Monday and reported on Tuesday, which tends to reflect limited clinic hours on Sundays. So we will certainly be delighted if we see a higher number reported tomorrow, but the typical pattern has been that the Tuesday lab reports tend to be the lowest of the week. I just want to make another reminder that anyone who has symptoms of COVID-19 can and should be getting tested. We know that there have been many mixed messages over the last couple of months about who can and can't be tested, but we just want to reassure people again that all the provider systems are now working very hard to have the capacity to be able to test all of their patients, all people who present to them with symptoms of COVID-19 should be getting tested or be getting referrals if a certain site is unable to test. We have a system set up where we're tracking testing availability around the state. So hopefully folks who are symptomatic should be seeing much better access to testing on a rapid basis. And just a reminder, when people test positive, or if they're feeling sick and they haven't yet been tested, how very important it is to stay at home and to self-isolate. That is such a key element of our Stay Safe Minnesota strategy that will help to continue to try to control the spread of COVID-19 in our communities. And once you do get tested, the clinic that does the testing is where you will get the results. So the clinic itself or the provider that ordered the test will be the ones to call you with your results. And depending upon which laboratory is processing the test sample, it can take several days for test results to come back. Some of the clinics are using laboratories, national laboratories that typically take a little bit longer to process and communicate the results. So just for people to be aware, sometimes the test can be several days. And we at the State Health Department are not able to respond if someone calls the health department and wants to know when they're going to get their result back. That is not information that's available to us until we get the report ourselves of the positive result. So again, while you are waiting for your test results, it's really important that you stay home and separate yourself from other people in your home as much as you can, and to do things like washing your hands very often and cleaning frequently touched surfaces in your home. With that, I'd like to just make a few additional comments about kind of what's changed and what hasn't changed. More specifically, what hasn't changed as we've seen more moves to turn the dial to open additional parts of our economy in recent weeks, including today. It's just so very important to reinforce what hasn't changed, as certain places of business have been able to reopen and certain social settings are also becoming more available to us. I know there are many different plans that different states and different groups have put out. Different experts have put out lots of different plans with multiple phases of what happens when certain criteria have been met. But overall, I think all of those different plans share some really common features or phases, and the first phase of which is really some pretty strict social distancing policies that need to be in place while the disease is still growing and still spreading in a community. The second phase tends to be very careful and staged reopenings, and not reopening everything at once, but reopening where certain conditions can be met, where a setting can manage the risk of exposure in that setting. So you've seen here in Minnesota with the governor's various decisions and announcements, so you've seen the emphasis on business environments needing to make preparedness plans for reopening to assure that they can protect workers and customers from the risk of exposure by doing things like screening their workers and their customers for symptoms before coming into the environment. Things like engineering controls that allow social distancing, spacing people out, literally moving merchandise and equipment and limiting the number of people that can be in the environment at any certain time. Cleaning, requiring the wearing of masks for workers and even customers. So at the business level, there's a lot that businesses are doing to try to reopen in safe ways as part of this staged strategy. But on the personal level, and the governor certainly mentioned this in his address last week, how just very important it is that all of us also continue to be part of this staged reopening. It's so very critical, as I've emphasized a couple times already today, that when we are symptomatic with anything, when we are not feeling well, we really, really need to stay home and isolate. Just because more businesses are open, just because we're emphasizing the importance of social distancing when we're going out, wearing masks, none of that means that it's okay now to go out into the community when you are feeling ill and when you're symptomatic. And when you've been exposed, how very important it is to quarantine yourself. But I just want to reinforce, it's probably obvious, but bears repeating, I think, all the time, that just the fact that more businesses are open and we're so strongly encouraging people to keep a social distance of 6 feet and to wear masks when you're out of your house for any reason, just because we're doing those things does not mean it's okay to not quarantine or isolate yourself when you've been exposed or when you have contracted COVID-19. Just need to reinforce that those basics are still the absolute foundation of our individual and collective safety as we begin to move around more. And we continue to reinforce the importance of minimizing group gatherings outside your immediate household. We know that how very important it is to pay attention to situations that are that pose likely higher risk when you're in closer contact with people for a longer duration, especially in closed environments, that those are situations, frankly, to be avoided. We just also want to reinforce that as we move into these later stages where we believe that risk can be managed, it's just very important for people to remember that lower risk does not equal no risk. So the importance of these personal behaviors to do things like keeping your social distance and wearing masks are just so very important to help to further reduce that risk wherever and however it can be. So thank you for indulging a little bit more of that basic public health caution, but especially as we really understand that we are going to be in this phase of staged reopening for quite a while. The way to kind of live with the virus in an ongoing way is going to be with us, and it's going to really require treatment and vaccination before we feel that we can really say that the environment is it's manageable in the sense of the risk. We're going to really need to keep up these behaviors for a long time to come to be operating in the new normal. So all the differences and the different plans that you see across the states and from national experts, those kind of key principles really need to guide our behavior. So thank you for your patience there with that soapbox for the day. With that, I will invite Chris Erzman to add any comments, and then we can open up to your questions after that. Chris, anything you'd like to add?
Commissioner, I think you covered it all, so I'll turn it back to Mike.
Well, thank you both. We'll open it up for questions now, and again, asking that reporters limit questions to one primary question and one on-topic follow-up so we can get to as many outlets as possible. With that, operator, we are ready to take questions.
Yes, sir. And as a reminder, to ask a question, you'll need to press star, then the number 1 on your telephone keypad. To withdraw your question, please press the pound key. Please stand by while we compile the Q&A roster. And our first question comes from Jeremy Olson from the Star Tribune.
Hi, Chris, if you have the numbers available, please provide them. I was wondering about the latest breakdown of hospitalizations in Minnesota, who the COVID patients are, what their demographics are, that information.
So in other words, I can let you know that of our hospitalized cases, 76% have pre-existing conditions, and just a minute here. If we look at hospitalizations, I've got the numbers for the total by race, and I think it may be, well, I can read them out, but if we look at the total hospitalizations, so in other words, 2,128 individuals who have ever been hospitalized, this is their how they identified themselves for race. 926 as white, 432 black, 133 Asian, 2 as Native Hawaiian or other Pacific Islander, 46 as American Indian or Alaska Native, 35 as multiracial, 107 as other, and currently missing 447. So having given all those specific numbers, is that what you were looking? Is that the kind of information you're looking for?
I wasn't specific enough. You had data on outcomes for how many go to ICU, what their outcomes are, and that kind of data. You'd been reviewing each hospitalized case one at a time, if I'm not mistaken.
Oh, yes. Okay. And I don't have that with me here, but I am working on some data for you that you requested earlier.
Okay. Just a related question then is the relationship with obesity. Even if you look at the COVID-Net, the CDC's website, clearly a lot of patients who are hospitalized also have obesity at a higher rate than exists in the population. When you're thinking about social distancing or restrictions, stay-at-home things, how are you going to factor in things like that exist for such a broad share of the population? Are you going to be telling people who are obese or have hypertension to do things that others might not in terms of social distancing or restrictions? How are you going to deal with that?
Well, I'll start, and then the commissioner may also have comments. But I think, we were getting a lot of questions saying, well, if you're seeing, deaths in, the elderly or the most frail, and if you're seeing that, a large proportion of hospitalizations, individuals in intensive care, and deaths are all in individuals with underlying health conditions, why are you, having these restrictions for the whole population? And I think your point is an excellent one, that there are many of us within the population who may look completely healthy but have underlying health conditions. It may be diabetes, it may be heart disease, it may be lots of things, and we do have higher levels of obesity than we want to see in our population, and that too can be a risk factor. So those are all things that need to be considered as people are hearing the commissioner's admonition to social distance, to wear masks, to do all these things that we've advised, and that is that there's a large portion of our population that falls into the at-risk category. And Commissioner, I'll let you add to that.
Well, thanks, Chris. I think I think you covered it well. I think that is just our key point, is that as time goes on and folks are weary of the restrictions and perhaps not seeing the importance of some of these ongoing behavioral changes and changes in the circumstances of the environments that we're in, just wanting to reinforce why that is, and the fact that there is more risk than may be apparent at first glance, and that, as I said before, just because we're moving into lower risk environments and times does not mean there's no risk. So for people to have more awareness of what those risk factors are, so that we can all take appropriate precautions in things that we can control.
Thank you.
And our next question comes from a Mr. Tim Nelson from NPR News.
Hi. Wondering if you know how many serology antibody tests have been conducted statewide since the UMayo partnership launched back in April. I know there's a goal of like 15,000 daily tests. Are there any being conducted on an average day? Have you heard anything about results of these so far?
And your question, this is Commissioner Malcolm, your question is on serology tests in specific, is that correct?
Yes.
I do not have that with me at the moment, but I think let us do a little bit of research and we'll try to cover that in tomorrow's call. I know there is some serology testing going on, but I cannot quantify it for you today. We'll bring that back. Thanks.
And as a quick follow-up, has the FDA's further guidance on that? The deadline was today for some more data about efficiency or about effectiveness and accuracy. Do you think that has curtailed some of this testing?
I think that it's probably a good thing that there's been more attention, more awareness, certainly among professional circles, as well as with the public at large, that more needs to be known about serology testing and it's what we know and what we don't know. And I think we've heard our clinical leaders in Minnesota saying over and over again, serology testing really is not valuable yet at the level of an individual, that we don't know enough to know for sure. Does a negative serology test mean that that you're, or a positive serology test in the reverse doesn't necessarily mean, well, you now have immunity. You're not at risk for reinfection or for infecting others, and we don't know that at this point in time. So I think the value of serology testing so far is more about the population level. It can help us to better estimate the exposures, folks who've been asymptomatic, who've not had a positive PCR test, but still may tell us more about the spread of the disease. But these are great questions, and it's quite a topic of a lot of research. So we will pull together some better data and bring that back in a future call.
Thank you.
And our next question comes from a Jeff Wagner from WCCO.
Thank you for taking my call. With more businesses reopening today, creating more opportunities for community transmission, more people now gathering in groups of less than 10, what is the state's preparedness level on contact tracing? How many people have been hired or reassigned to that job at this point, given now that there's just more opportunities for people to interact in public and transmit the disease?
Thanks. It's a great question, and that's absolutely right. As we get to the point where more and more of society is opening up and more of our containment efforts need to be focused on specific settings of higher risk or where there are outbreaks in certain communities or certain settings, that contact tracing becomes more and more important. And we have been building up our staff capacity significantly in recent weeks and training more people that assist with case investigation and contact tracing. Chris may have the specific numbers right at her fingertips about how many staff have been added. It's in the hundreds in recent weeks. And we are working toward toward a couple of different goals between now and June 1st and then longer term. Chris, can you cover that?
As of Friday, we had 400 staff doing case investigations, contact tracing, and we were adding, there's additional staff that are here today, or not here today, but are in the process of being trained. So, yes, we are adding, I think, an additional 100 staff this week, so we're continuing to add staff.
And I think our goal is something like 1,400 staff that will be added, or 1,400 total case investigators and follow-up contact tracers between now and June 1st, and then longer term, as we continue to develop new approaches to figuring out what an expanded testing regimen and retesting in certain environments is going to require in terms of added staffing beyond that. We are also working on that longer term plan.
Can I just add one thing, though, and that is that, as we are ramping up for case investigation and contact tracing, I think one thing that people should realize, and the Commissioner alluded to this in her early remarks, is that if you have symptoms and you have gone in for testing, that you really need to stay home until you get those test results, and you should be thinking about, okay, if I'm positive, who have I been around and who may my contacts be, so that we can be proactive in getting that information out and letting people know, hey, you have been exposed to someone who has COVID and you should stay home, so that the individual who's getting tested can also be a partner in the response.
And as a quick follow-up, you get another day, another 700 cases. The people who are doing the contact tracing are likely still working on a previous case. Now there's another 700 today. Does someone just get 5 more cases, or do they have like a certain allotment they're only allowed to work on at a specific amount of time, since the number of cases rises by the hundreds, but we only get 100 more contact tracers each week?
We have a rolling queue, and it's a situation in which they may try to call you, and you may not pick up the phone, and so then they will go to the next person in the queue, but there'll be a note that's made that you were called, and then they will continue to try and call back. So it's a rolling queue, but yes, people are continuing. I mean, it's one of those things where, unfortunately, you never get to the finish line, because just as you're celebrating the success of the 700 people that you interviewed yesterday, as you said, you get, many more that next day. But it's a rolling queue, so that no one ever gets to the end of their assignment.
Thank you.
And our next question comes from a Mr. Matt Sepik with NPR News.
Hi there. I'm not sure if Dr. Linfield is on the call, but I'm wondering if there is any update today. And she said there might be more information this week about multi-system inflammatory syndrome in children. Have there been any cases identified here in Minnesota? I know Dr. Linfield said that there may be cases, but she wasn't entirely sure on Friday.
Dr. Linfield is not on the call today. Ruth, are you aware of any confirmation of any of these cases in Minnesota?
No, I have not been made aware of any. And as you acknowledged, the health alert went out Friday, so we expect that it may take a little while for us to hear, but now providers are very much aware of the situation, so we expect that we will be hearing from them.
And then just a semi-related follow-up question. I'm wondering, is that Abbott rapid test that was so problematic, is that being used in Minnesota at all?
It is being used in Minnesota, and we are aware of where it is being used, and so have the ability to provide information to those users.
So is there a backup if this test is found to not really be working or giving false negatives or false positives?
These rapid tests were placed, earlier in our testing process when testing was not as widely available. And so our hope is that with the ramp up of testing across the state, that should help to alleviate any challenges faced with these particular testing systems.
Okay, thank you.
And our next question comes from a Miss Emily Havoc from Care 11.
Hi, Jan and Chris. Thank you for the update today. Commissioner Malcolm, I actually just wondered if you could clarify a bit. You were talking before about asking people to still minimize public gatherings outside their household and avoid gatherings in closed settings. Can you speak a little to, of course, there's a sort of a maximum that the state is allowing under the order, but that might be a little different from what, as public health officials, you'd recommend. So can you just go into a little more detail about what you were talking about previously? What would you really advise in terms of gatherings outside of people's households?
Well, and I certainly invite Chris to chime in here as well. I think our guidance continues to be to minimize gatherings of groups any larger than 10 outside of your immediate household. So but to clarify that, I think if you have a large family, large household of 8 people, that doesn't mean, your household 8 can gather with 10 more. We're really talking about group sizes of 10, including those in your immediate household, as being, I think, kind of where our guidance has been and remains as of today. Just again, because not that there's magic in those numbers, but just as a kind of an acknowledgement of the fact that there is still community transmission going on, and it's not all isolated to specific settings, be that long-term care or the food processing plants or other higher risk settings. So we just want people to be aware that there is community spread still going on, so that it's really, really important to keep that social distance and wear masks and not be doing as much interacting as we would all love to be doing, just to be mindful of the need for less interpersonal contact.
Thank you. And then this might be something you need to get back to me on, but regarding the numbers of healthcare workers infected, I know you've been updating that on the situation update online. Is there any data on whether those healthcare workers had PPE or whether there was any issue with the PPE in those settings?
I'll hand that to Chris, but I'm guessing that would probably be a level of detail we don't have. But Chris often surprises me with how much detail she has.
No. You know what? That's something that I will check on, but I don't know that we have that information. we do know the number of healthcare workers that were under monitoring and that, test positive, but I will follow up and see if we have information on PPE at the time.
Thank you, Chris. And then just to clarify, because I've heard a couple, I think this has changed a couple times, the number of healthcare staff you have listed online, were those people all now infected in healthcare settings, or does that still include people who were infected in other places and just happen to be healthcare staff?
It is, I believe it is, it is just that they have a job as a healthcare worker. And what's significant about that is that because they have a job as a healthcare worker, they are followed up with a unique team who specializes in making sure that their situation is evaluated in light of the potential exposures that they could have had in a healthcare setting, as well as the potential exposures that they could have made in, so not themselves, but that who they could have exposed in a healthcare setting. But no, it's not. It doesn't mean that their exposure occurred in a healthcare setting, just simply that they are healthcare workers and that our follow-up of them is really quite rigorous because of the potential for transmission in their work setting.
Okay, thank you so much.
And our next question comes from Mr. Dave Orrick from Pioneer Trust.
Thank you. Just very quickly, and then I'll have a follow-up, but a couple of times now I've heard you guys say wear a mask or face covering anytime you leave your home. I assume you don't mean that, right? You mean anytime you leave your home and are going into a setting where social distancing could be difficult. Is that correct?
Well, thank you for the opportunity to clarify that, Dave. I think we actually are saying we recommend the wearing of masks either indoors or outdoors. And I know that there are various opinions out there about whether outdoor masking is as important. But we do believe that it's a good idea to be wearing masks even when you're social distancing and even when you're outdoors as an additional precaution. The more we learn about the role of the ability for the virus to transmit, even when people are talking. It's not just coughing on you, but some recent analyses have shown that talking can be a risk of transmission. Even though that it certainly is a more concentrated risk in confined settings or in enclosed settings, currently we might think of it as just additional layers of protection, that any one thing by itself is not the sort of the magic protection, but the layering of these things together, social distancing and masking and avoiding confined spaces and close encounters for long periods of time, all of those things together add up to pretty good levels of protection for people. So, Chris, you want to clarify further or add?
No, I think that well, I guess the one thing I would say is if you are going out jogging and it's difficult for you to jog with a mask on or something like that, I can understand where a person would say, not in that setting, and you're moving in such a manner that you're not going to probably encounter people. But yes, even if you were having people to visit in your backyard and you intended that you were going to, all be 6 feet apart, wearing a mask is just the belt and suspenders. It's doing both the social distancing as well as it's that added protection of source control with the mask.
Okay, thanks. That helps clarify that. You spoke earlier, Commissioner, about businesses and customers and employees wearing masks. I've been out in stores and seen very few employees wearing anything over their face and even fewer customers. What are we to do with businesses who are not following this? And many of us on the call last night watched our lawmakers at the Capitol, many of whom were not wearing face coverings indoors, speaking fairly closely as well.
And thank you. And, I should be clear that the guidance and the recommended best practices And what a lot of businesses are doing themselves of their own volition have been to require the wearing of masks in their setting. But that has not been, that's been guidance. It's been recommendation, not a requirement, to this point. So we're just, I think, wanting to be more specific and more clear that is what is recommended and that is best practice, and a little bit more detail on why. As we learn more, some of this new data about just on a CDC call this morning, hearing about the studies that show the measurable risk of virus transmission from normal volume talking, conversational level talking, and then higher levels of risk for loud talking, such as you might encounter in a louder environment, for example. So the more we learn, the more we just want to, and hopefully it's helpful to people to understand there are some real reasons for these recommendations. It's not just, it comes from growing concern about risks where we maybe didn't fully appreciate the risks before.
Okay, yeah, but it's not working.
Understood. That and that is a concern. That if people don't see the need for it, or for some reason don't think it applies to them, or think, as Chris said, as long as I'm 6 feet apart, the mask isn't important, and some of that we need to do a better job of educating. And I think as more data comes out, hopefully people will find that persuasive. It isn't just some nerdy public health advice. It comes from actual evidence that there is risk of transmission where we didn't previously appreciate it.
Thanks.
And our next question comes from a Tom Liddon from Fox 9. Hello, Mr. Tom.
Sorry, can you hear me now? Can you hear me now? Hello?
Yes.
Yep,
yes,
yep.
we can. Go ahead.
Great. On the dashboard today, it says 592 ventilators are being used. We have a capacity for about 3 times that. My question is, does that surprise you, and why are few people apparently going on ventilators? Is this about the concern for the outcomes, that people are staying in long-term care and not going to the hospital? I'm also wondering if MDH is tracking the outcomes on ventilators. Staff told me a couple weeks ago you had completed case reviews of 416 hospitalized, 56 on ventilators, but you didn't have any outcome on data on outcomes, which surprises me because obviously studies have shown between 60 to 98% fatality rate depending on age. So are you tracing those outcomes?
Chris, I'll let you speak to whether you've got anything on that. What I would suggest is that we perhaps get Dr. Hick to join us again for a call, or one of his colleagues, to give you a little bit more insight into what we know about ventilator use and ventilator outcomes. I know he's tracking that data very carefully nationally, as well as if we have some Minnesota-specific outcome data. These are, even though the numbers are growing, they're still relatively modest numbers from an analytics standpoint. But certainly we'll ask Dr. Hick to join us.
And I'll just say that, yes, we are doing follow-up on all of our hospitalized cases, and I can check to see if they're, looking at outcomes for that. But I know that we're doing follow-up, and we are following up on all of our deaths, so we should be able to potentially link the two, but I will check on that.
Since that was a quick answer, I'd like to ask a quick, slightly different topic follow-up, and it's really a follow-up to Oric's question, and that is, because we have so many people who are, who don't seem to be wearing masks, at what point and how many days will it take before MDH has a sense that there has been a severe uptick in cases? For example, obviously a lot of people are returning to work today. How long, and I guess this is an incubation question, how long until MDH gets a sense about whether we've made a significant mistake in doing this?
Chris, can you take that?
Yep, the incubation period is 0 to 14 days. And I think, given the fact that people generally don't get tested the first minute that they may develop symptoms, I think it'd probably take at least 2 weeks, because we have to give time for the incubation period, and then probably give another week to allow for some testing and resulting of those tests. So I would say probably 21 days.
Thank you. Operator, we have time for one more question.
Yes, sir. And our last question comes from Mr. Chris Rogers from Winona Post.
Thanks. My question is about long-term care facilities and the 5-point battle plan. You talked about some of the progress, Commissioner Malcolm, that you've made on that. I wanted to ask about the plans that you were hoping all long-term care facilities would develop to better prepare for COVID outbreaks. How is that going?
Sorry, I was on mute there. I think the teams that we talked about getting in place, and including much more involvement of our local public health colleagues in these teams that are working with each facility, it will be the role of those teams to really not only coach, but really kind of make sure that the facilities are producing those more detailed plans going forward. And that so I can't tell you numerically, how many facilities have updated their plans in the last week, but that is data that we will build.
And did I hear you correctly that you're really relying on local public health departments to work with long-term care facilities on those plans?
Well, I just wanted to say that is one of the ways that we're beefing this up, is by including local public health in the teams that previously had been mostly state health department staff. It's both to augment our capacity, but also to better connect the facilities with local partners that can help on a whole range of topics. And certainly, I don't mean to say local public health hasn't been involved before now, but just kind of being more intentional about strengthening their role in these teams is really what I was intending to stress.
Thank you.
Thank you to everybody. That's all the time we have today. I do want to thank our speakers and the reporters on the line. If you had a question you were not able to address during the call, please feel free to reach out to our office at 651-201-4989. Have a good day, and we will talk with you again soon.
This has been a WDIO News Special Report.